Welcome back. For the next 20-30 minutes, I'll take you through the lymph node imaging. Initially, I thought I will cover entire aspect of sentinel node imaging, but I will talk only about oral cancers. I think majority of you perform for melanomas and breast cancers, and I will talk about oral cancer and the role of sentinel node imaging. And I will cover the basic introduction, principles, indications, pharmaceuticals, and what is the current literature on role of SPECT CT in oral cancers. In fact, sentinel lymph node biopsy is a minimal invasive procedure to determine the disease status in the lymph nodes. In fact, in 1977, the first lymphatic mapping was reported in patients with penile cancer, and in 1992, Morton was the first guy who reported the role of injecting intradermal isosulfan blue for the assessment of lymphatic mapping in patients with malignant melanoma. And in 1993, Alex et al. Reviewed the peritumoral intradermal injection of radiotracer followed by intraoperative gamma camera for the role of assessment of sentinel lymph nodes. Lymphoscintigraphy and biopsy for oral squamous cell carcinoma was first described in 1996, and we do quite frequently in our hospital, about 3 to 4 per week in patients with oral cancer. We do perform sentinel lymph node biopsy. And the basic principle is you inject around the tumor, about 3 to 6 injections, but in general, on average, we inject 4 injections. And the first node we see is the sentinel nodes, and often we can see second tier or third tier lymph nodes, just like in melanoma or in breast. Sometimes, if the closest lymph node is studded with metastasis, it can skip to the other side, so that's one of the false negatives you need to understand. And the principle and the concept of sentinel node, which majority of you will know, but I will just take you through just as a part of the talk. First lymph node to be visualized by the draining from the tumor is free from metastasis. Highly unlikely that the subsequent lymph nodes along the pathway will be positive. Therefore, a complete lymph node dissection can be just avoided. If the first node, whatever you take out, is negative, then there is no need to go for an extensive surgery in these patients. So, rationale is to preoperative lymph node, you address the surgeon, which is the most likely lymph node. You need to have a dynamic images, are very important. Although the technology may progress into hybrid imaging, there are quite a lot of things which have changed, which I will show you. We have intraoperative gamma counting system, but dynamic imaging cannot be replaced. Whatever the technology comes after that, every patient who is having a sentinel lymph node, especially in melanomas or in oral cancers, dynamic imaging plays an important role. Advantages of sentinel lymph node biopsy: it reduces the morbidity related to unnecessary neck surgery. Patients undergoing sentinel lymph node have significantly less postoperative complications, and variability in lymphatic channel has to be taken into consideration. So, by doing SPECT CT or doing dynamic imaging, you can assess the expected pathways of sentinel node mapping. What are the common indications? They got a strict criteria here. You have to assessment of ipsilateral clinical node negative. On palpation, if you find a lymph node in the neck, then the patient is not going to have a sentinel node imaging. So, on palpation, there should not be any palpable lymph nodes. And assessment of bilateral clinically node negative tumors. So, it has to be node negative bilateral. If you have a palpable node, then there is no node for sentinel node biopsy. Inclusion criteria is very important. You have to do a physical examination. In a clinically negative neck, you have a contrast enhanced MRI or an ultrasound is commonly performed in all these patients, and they also do PET CT in all these patients. But the problem is, which is the preferred modality? It's quite challenging because none of them have got an ability to detect macrometastasis, and all techniques improve on sensitivity on palpation alone. Therefore, recently, though they have said PET has got highlighted as a high specificity, and also they do PET CT. Even if PET is positive, then people really don't go to do sentinel lymph node biopsy only when PET is negative. And if all other examinations are negative, and that's indication for oral sentinel node biopsy. Exclusion criteria: if there is a gross lymphatic involvement, you often palpate the lymph nodes, and then Sentinel node is therefore contraindicated if you have a clinically staging positive NECs. On examination or in any other imaging, you have got an enlarged lymph nodes, then that you have to go for a normal surgery rather than going first for the sentinel node biopsy. Common radiopharmaceuticals is NanoColloid. NanoColloid is combined with technetium, becomes technetium NanoColloid, and it is injected into the patient. There are other components like sulfide colloid, rhenium, as well as NanoColloid, because NanoColloid contains human albumin, and they are trying to introduce a new compound called as a lymphoseek, which they found to be quite useful, but the only problem with that is it's going to be slightly expensive when compared to these compounds. Technique is quite straightforward. Usually if it's a tongue lesion, it's quite easy. The problem comes whenever they have a lesion in the floor of the mouth, but if it's in the tongue, you have to inject 4 injections in 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock positions, and it's a submucosal injection, about 0.1 ml per syringe. If you have 4 injections, it will be 0.1 into 4, and patient should rinse the mouth, not to swallow it. Once they swallow it, then it becomes a problem because it goes everything in the esophagus, and it becomes challenging in terms of localizing the lymph nodes. They just rinse the mouth and throw the water out. That's the 4 injections we give. So if it's, you can do it as a single day protocol or a 2-day protocol. If the surgeon is planning to perform the surgery in the afternoon, we usually inject in the morning. We inject and scan the patient, then the patient goes to the theatre. But if the surgeon is planning to do early in the morning, it's better to do the day before. So what we do is we inject around 3 o'clock or 4 o'clock in the evening, do the procedure, label the lymph nodes on the skin, send the report to the theatre so that the surgeon can operate 8:30 or 9 o'clock in the morning. So if he's planning to do in the afternoon, it's better to do as a 1-day procedure. If you're doing as a 2-day procedure, you need to give slightly a higher amount of activity, because it has to stay for at least at the time of surgery. You should have at least 10 megabecquerels at the site of surgery to pick up the nodes with your probe. Otherwise, it's going to be challenging. Maximum is you can go up to 48 hours, I think so. It depends again on the surgeon. So people still go up to 48 hours and wait for the procedure. Imaging dynamic is most important. Again, the protocol varies from various hospitals. In our hospital, we perform 45 minutes of dynamic images. Then we do the static images and mark them. That was the standard procedure we used to use in the past. Now for all head and neck cancers, including melanomas of head and neck, we do SPECT CT in all these patients, because that's what the surgeon wants. So without a SPECT CT, surgeon is not going to operate in our hospital. So he wants a SPECT CT. Or you can modify the protocol. If you think your workload is too much, you can do 30 minutes of dynamic, stop it, and then 2 hours later you can do a SPECT CT or a planar imaging. So wait for 2 hours after the dynamic, and then you get an accurate mapping of the lymph nodes in these patients. And if you're imaging, it depends which part of the oral cavity you're imaging. If it's in the left side of the tongue, it's better to have a left oblique, anterior oblique, or a left lateral images, or vice versa. But if you have to take anterior images if the lesion is in the floor of the mouth. The reason is if it is in the floor of the mouth, it can drain both sides of the neck. But if it's on the right side, most often it drains to the right. If it's in the left, it goes to the left. But if it's in the floor of the mouth, most often the lymph node drains bilaterally. Therefore, it's better to take an anterior image. Imaging should be performed. All these things you know, because you routinely do melanomas. It's the same. You have to scan as soon as you start. You have injected. Sentinel nodes are identified as 1 or more focal areas. It could be multiple, it could be single, it could be unilateral, or it could be bilateral. Even if you are injecting for a lesion on the right side of the tongue, sometimes you may get a contralateral side. There may be an isolated lymph node. So if it goes to the contralateral side, that also becomes a lymph node. So the surgeon has to look at both sides if it goes contralateral. This is all the dynamic images. You inject. This is a case of a melanoma, although melanomas is easy because you often see a lymphatic channel, but seeing lymphatic channel in oral surgery is difficult because the primary site and the nodal drainage is very close to each other, because you're injecting into the tongue and you are trying to look for the lymph nodes in the neck. So the activity injected is so hot, then it's not easy to see these channels. you get multiple channels like this. So why dynamic image is important? It is important to see all this lymphatic channels, because the lymph node can drain into multiple channels. If it's draining into multiple channels, individual channels is a site for a lymph node. If it's a single channel, it is easy to say the first one is the sentinel node, the one which is distal to it is the second tier nodes. But if you see two channels, so each individual channel is giving rise to a sentinel node. So all those has to be excised during the surgery. This is the local view injected into the tongue. Better to take the lateral view, but only problem is because it is so hot, you can't see quite a lot on the dynamic images. Unless you mask the images, you often can miss quite a lot of lymph nodes, especially if you are injecting into the floor of the mouth or even in the tongue. It is quite challenging to localize lymph nodes in level 1A and 1B in the neck. 2 is okay, 2 is slightly away. For example, the 2 will be somewhere here, it is easy to recognize. But if you are injecting in the floor of the mouth, there may be level 1, level 2, level 1A and 1B lymph nodes will be quite challenging because it's very close to the injection site. So therefore, SPECT CT will be useful in these patients. Image interpretation, it varies. There are various definitions. One of the definitions is lymph node close to the primary lesion is taken as a sentinel node, or the first lymph node depicted on a lymphoscintigram could be a sentinel node. Lymph node with the highest count rate, the hottest nodes, they take it as a lymph node, or any radioactivity at the time of surgery, if it's hot, they take it as a lymph node. So it varies between the surgeons, but majority of the surgeons are really happy with you only when you show them one node. So they don't want to go there and do quite a lot of surgery. They're not happy with that. And lymph node with a count rate that exists a certain fraction of the hottest node. So even there are multiple nodes, the surgeon usually will pick up the hottest node as a sentinel node. And also some centers will have a combination of a blue dye technique. So if it matches the hot node with the blue node, then they take that as the lymph node. But the thing is, majority of the people now want to avoid blue dye technique, because with the blue dye technique and nuclear medicine technique, the sentinel node localization is 95% accurate. The only problem is they want to get that extra 5% so that they can be definitive. So that's why the recent technology of SPECT CT and all other things which I'm going to show has come into place. And some hospitals, they don't do combination of both. Only when they are not happy with your sentinel node imaging, they do a blue dye technique in association. False negative occurs because there is the presence of metastasis and non-sentinel lymph nodes, when the sentinel nodes does not contain metastasis. That's what you asked. And also the appearance of metastasis during a follow-up in that particular lymphatic basin, which we sold as negative to start with. If it is a positive there, then it is a false negative area. Sometimes you inject, and strictly speaking, as soon as you inject, you have to see something in the neck. Even if it's a melanoma, as soon as you inject, within a few minutes, you have to see a lymph node. But if you don't see, most common problem in this is injection technique. If you go little bit deeper, then it takes a longer time for it to move. And the injected volume and the activity, if it's a small volume, most of it gets stuck to the syringe, and therefore you will not get it. And if the nodes are very close to the injection site, then you can't localize them accurately because of the scatter, and because it's so intense, you will miss the nodes very close to the injection site. In those cases, people advocate like you can do delayed imaging. In some centers they do up to 3 hours. In some centers, if you don't find it, you can scan them up to 24 hours and see whether you get lymph nodes. Multiple views is important, especially if you're injecting breast and other things. There's quite a lot of attenuation, and often the simplest thing is to move the breast away. You often see the lymph node there, but if you don't move it, then it's going to be a problem. SPECT CT is useful because it picks up more nodes when compared to the conventional two-phase, conventional dynamic and static images. And in spite of all these things, if you're not located, then you can also try re-injection at that site. Report, ideally you should tell where you injected, how you injected, and how much you injected, because that's important in terms of the radiation dose. Timing of what time the first node you are seeing it, so that will be the first node. Number of nodes, and marking is also important. It is better to discuss with the surgeons exactly in what position they want us to mark, because we may mark in a different angle and view compared to what position the patient is in the surgery, so that causes quite a lot of problem. Coming to radiation dose, how much does the patient get? They get around 0.2 millisievert, and the surgeon gets a maximum dose of 2 microsievert per procedure. Though the surgeon is very close to the patient during the surgery, the whole body dose is more important rather than the local dose. So if a surgeon has to get 1 millisievert radiation dose, he has to do up to about 400 surgeries per year. Only when he does 400 surgeries per year, then he'll exceed more than 1 millisievert. Therefore, they're quite safe. If the patient is pregnant, they can at least see up to 150 cases per year. If he's a nurse who is a scrub nurse in the theater and she says because it's radiation she doesn't want to work, you can say you can safely do up to 150 cases a year. Even then, she's not going to exceed the limit. Coming to clinical examples, this is a case where we injected into the left lateral border of the tongue. Nodes are not marked. This is seen quite clearly seen, but what is happening here is quite tricky. You don't know whether it's a lymph node or not in those conditions, and also it's very challenging to mark it with your on the skin. Whereas on the SPECT CT, we can at least localize and say there is a lymph node close to that particular organ or a muscle or a bone. Then it's easy for the surgeon to localize, and that's where we can help. But marking will be challenging. But on the lateral, you are seeing 2 nodes, and all these 2 nodes will be marked and it will be removed during surgery. These are the planar images. Again, it's quite challenging. It's a tongue SCC. We injected, you have to mask it, and then you see 2 nodes. Other on the dynamic, you say very faint uptake because in spite of marking, you're seeing quite a lot uptake, low-grade uptake, because the injection site and the lymph nodes are very close to each other because you inject, and most of the cancers in the oral cavity drain to level 2 lymph nodes. So you have to be careful at that area. This is another injection why you need to do masking. Masking is important. Without masking, you will miss few nodes in this area. You have to mask it. Then the masking again is the technology should be trained how much to mask, because sometimes they'll include the node also very close to that region. So you may miss the node by that. And too small marking or too big marking will cause problems. So you have to be clear how much you want to mark. And you should also, esophageal activity will be a problem in oral cancers, because after you inject, you tell the patient to rinse the mouth, and sometimes they swallow it. If you have a swallow, then it becomes a problem. And this, you will not know whether it's a lymph node or it is esophageal activity. But if you do a SPECT CT, all the tracer will be in the esophagus, and therefore you can exclude that area as a lymph node area. Recent advances in sentinel node imaging is SPECT CT is one of the recent advances, and also now they have a freehand SPECT or a 3D SPECT where a surgeon can use this in the theater. Sometimes we inject the patient, actually we are doing a study looking at how soon we can pick up nodes in the neck. So I inject the patient in the theater. Within 5 minutes, using a freehand SPECT device, the surgeon can tell if it's in the level 2 or 3. So the plan is some stage during our journey, all these surgeries, especially the parathyroid and the sentinel node imaging, will move into the theater. It will be radar guided surgery. All the patients will be injected into the theater, especially if it is a oropharyngeal or laryngeal carcinoma. You can't do that procedure in nuclear medicine department because that has to be done under GA. So therefore the patient has to be injected in the theater. Currently we do quite a lot of prostate cancers, and the plan is to also do for lung cancers, to inject around the tumor peripherally in the theater and wait for approximately half an hour and to check whether it is drained into any mediastinal lymph nodes. So the indications for sentinel node imaging is vast. In fact, you can do it in any tumor now, and the future will be they'll be planning to do in patients with the colorectal cancer, esophageal cancers. All this will be under radar guided surgery. So the plan for the surgeons is to move into the theater, so that we have to go there, inject into the theater. Within half an hour, using this 3D probe, which I will show you, you can detect the lymph nodes. And some surgeons, though you image them, they also have a portable gamma camera in the theater, so that what happens is they resect the nodes and they will re-image the neck or whichever the area they're going to operate. So if there is no radioactivity in that area, it means to say they have done a full total resection. And people are moved into radio tracers. What we do in our department for patients with oral cancers is we label technetium nanocolloid with ICG. ICG is indocyanine green, which is a fluorescent agent. So the labeling is very simple. So it takes very minimal time. I mean, it doesn't even take any time. It just add ICG to the technetium NanoColloid. It's in the same injection. We inject into the patient. So what happens there is, I will come to that shortly. And also the radiologists are interested now. So they inject magnetic particles to assess where the central node drainage is. So all these three things, especially these two things, just to increase the specificity in picking up the last 5% of the nodes. Hybrid imaging is useful. The principle is very simple to accurately localize the surgeon. That's what SPECT CT and lymph node mapping is. So current evidence is quite a lot of papers looking at it, but all the papers say they could pick up extra or additional lymph nodes and better localization and precise anatomical localization and better detection of sentinel node close to the site. So to summarize all these things, they pick up more nodes. It is easy to localize nodes close to the injection site, and also to give exact level of localization. Therefore the surgical time is reduced. The surgeon can easily go, whether it is anterior to the sternocleidomastoid mastoid or posterior, then it's easy for him to just go and pick up the nodes at that site. This is an example. This is what I was saying about volume rendering. These are the images. If you have this package with you, in fact this is not that good. In fact, you can get a patient's image, you can just see the patient's face in that. You can get so accurate images, saying that you can say it's quite challenging because now you have to mask the patient details and all other things, but the volume rendering is so good, it is exactly like taking a photo picture of this patient. So this is the patient we injected around the pinna, and as you can see there are multiple nodes, and it's on the SPECT CT is easy to localize all the nodes. And for the surgeon, this is the type of images he wants. It's easy for him to think in terms of 3D, and he can plan his approach, like which side he is planning to go. Another patient, sentinel lymph node localization in oral cancer. We injected in the mouth, oral carcinoma. As you can see, there is a one node on the anterior aspect. With SPECT CT, there are two lymph nodes at level 2. There's another node. If you have an image like this, it's quite challenging for the surgeon, because if he's using the probe, because the injected activity will be so high, it is very difficult for him to differentiate the injection site and the lymph nodes, because it's very close to the injection site. So with the SPECT CT, it is easy for him to localize. As I said before, if you have at the floor of the mouth or at the base of the tongue, if you inject, it's going to drain bilaterally. So bilaterally, it is a level 1B nodes. And especially if your activity is too much, if it's very too hot, then you're going to miss these nodes. So you will go only to the level 2 nodes. So therefore, with the SPECT CT, you can get accurate mapping of the nodes close to the injection site. This is another patient. We also do patients with the parotid gland. If there is a carcinoma of parotid gland, we do sentinel node, ultrasound guided. We inject into around the tumor, image the patient. This is the patient with an mucoepidermoid carcinoid of the right parotid gland. We injected around the same spots based on the ultrasound, and we could find a level 2 lymph node. So far we have done about 3 cases, and we are trying to expand this service again. This is the 3D mapping which they have. It is exactly the device like this. You inject the patient, I inject the patient, and the surgeon wants to, within 5 minutes or 5-10 minutes, he could just localize nodes like that, and he knows that exactly where the nodes are. But the only problem is he will miss the dynamic images. So you have to convince the surgeons. I have no problem for them using this in the theater, but it will not replace the dynamic imaging. Therefore, nuclear medicine is safe. You have to tell him half an hour I will image him, do dynamic images, and after that the surgeon can operate in the theater. The beauty of this is it will tell you exactly at what angle it is and what depth it is, and it will help the surgeon plan. And this is what we do now, though it costs about 120,000 pounds, I think so, to buy this device. It's quite larger than this whole device is there. And we have moved a little bit extra. What we do here is we inject the patient in a nuclear medicine department. We do all the dynamic images. Later on, for the SPECT CT, we place this device in the head. That is the marker. and the same marker the surgeon will place it during the surgery, and with our CD pictures which we send to the patient, they will do what is called as 3D navigation. Based on that, you can accurately go and remove the lymph nodes with 3D navigation. That's what they do in the theater for all prostate surgery in Netherlands, and it's quite nice. And the more nicer thing is what we do now is NanoColloid Technician, that's the standard tracer, but we add ICG, which is a fluorescent one. So we add that, inject into the patient, and the beauty is nuclear medicine with a probe you can hear the noise, is radioactivity, but with fluorescent the surgeon can see the nodes in the theater as green lights. So what we do is we inject them together, we do SPECT CT, with a probe they find exactly where it is, you open the region of interest, and we have a fluorescent camera, place the camera there, and it comes as green lights. So with this they can see the node as well as hear the node. So seeing is better than hearing according to the surgeon. So in all oral cancers now in our hospital, we do fluorescent imaging along with NanoColloid, therefore to pick up nodes. And the highest number of cases, I think so, they do quite a lot in Italy and Netherlands, where they have done more than 2,000, 3,000 cases. In fact, they have done around 700 patients for prostate cancer. So without sentinel node imaging with NanoColloid and ICG, the surgeon doesn't operate at Netherlands Cancer Institute. All patients will have sentinel node mapping early in the morning. They start around 8 o'clock. They complete the scanning by 1 o'clock because they scan for 15 minutes dynamic. They inject the patient in the outpatient department. Then the patient walks to the nuclear medicine department. We scan the patient for half an hour, and then 2 hours later we do SPECT CT, and then the patient goes to the ward at 1 o'clock sharp. The surgery is over by 4 o'clock. It's all robotic surgery, and that's where nuclear medicine is going now. And the indications are you can use it for gynecological malignancies, you can use it for prostate cancer, bladder cancer, all types of cancers. You can use ICG with NanoColloid. ICG is also licensed because they use fluorescent imaging in cardiology, and therefore it is not a problem to get authorization from the health department. Frequently asked questions is sentinel nodes are usually detected 15 to 60 minutes. So if you don't detect, what you're planning to do? One of the commonest problems, if you don't see a sentinel lymph node, it means it's an incorrect technique, or it is close to the injection site. Metastatic deposits, if it's a palpable node, you shouldn't have done it, but sometimes even a smaller lymph node may have metastasis, so that may block the drainage of the lymphatics. If nothing helps, you need to do, in SPECT CT you always pick up, if you have all these problems, if you do a SPECT CT, because of its resolution, you will see some lymph nodes. In spite of doing SPECT CT, if you are not picking up a lymph node, the patient has to be re-injected. Injected activity, again, you can do as a 1 day or a 2 day protocol and tweak your radio tracer. You can't use the standard protocol like 10 megabecquerels. You have to discuss with your surgeon how much he wants us to inject, because the lesser the injection you inject, the easy for the surgeon to operate, because it's a very closed area. Whereas if it's a melanoma, it is easy because you're injecting in the foot or in the limb. The drainage is about quite longer. For example, if you inject in the thigh, the drainage is in the groin, so it is easy for the surgeons to use the probe. But if it's head and neck, it is quite challenging to use the probe where the primary site is close to the lymph nodes. Radiation protection, as I said, the surgeon's hands are exposed, but the whole body is more important. Surgeon can safely perform up to 400 operations per year, and the safety limit for the public is about 1 millisievert. Now the most important thing is the typical radiation from chest X-ray is about 0.02 millisievert, return flight from London to Spain. So if you have 100 airport security scans is equal to 1 chest X-ray. So if you travel 100,000 times a year, 1,000 security checks, that is the radiation you get is just 1 X-ray. So you should not worry too much about radiation. So the team, you should have a surgeon, because any sentinel node service anywhere in the world, it is surgeon driven. They want it to be done and they are passionate about it, so we should be supportive. If you want to expand the service, we should sometimes spend time with them in the theaters, because you should go over the theater, discuss with them and chat with them and ask them when they want to be done. And we have to be quite flexible. We need to have a nuclear medicine physician, we should have a radiopharmacy and technologist, and there is a significant role for sentinel node imaging in patients with oral cancer. SPECT CT complementary is the same. You can visualize nodes which are not seen on the planar. You can pick up false positives and alteration to the surgical approach. So all surgeons, like in our hospital at least, all patients with oral cancer who fit the inclusion criteria will have sentinel node imaging with ICG and NanoColloid, followed by SPECT navigation and SPECT CT. All are done.